radiotherapist oncologist to work at the Cruces University Hospital. And due to my background and where I studied, I've been lucky enough to be involved for many years in the management of prostate cancer. In fact, for many years, I just treat palliative and genitourinary cancers. And at least my activities in a public hospital, I do lots of prostate brachytherapy, but also hypofractioning and CVRT. Although I know you have big stars, prostate stars, as Dr. Fausky and my friend Mark Roach. I'm going to talk about this a little bit because if you're using hypofraction, it is important to know what we're doing today. So, as I mentioned, I started the brachytherapy program in my hospital many years ago. Prostate brachytherapy, yeah, and in the last couple of years, we are working with a big change in technology, and I'm going to share with you how we've changed from conventional hypofractioning to what we do today, which is extreme hypofractioning in prostate cancer, and why still we do hypofractionated treatment. So I'm going to share some evidence, and then we will dive into the two most important trials, those who give are the basis for moderate hypofractioning, which is CHIP. It's a British study, and the profit study from uh, Canada at the Princess Margaret Hospital in Toronto. It is evident in general in cancer, but especially in prostate cancer, that there is a relationship dose response. So, from the point of randomized trial of those important ones, have demonstrated that when we increase dose in the prostate, we improve global survival rate in patients. Also, to be fair, we need to say that the studies, all these studies that I'm mentioning, none was designed to demonstrate these survival increase. So what does it demonstrate? Well, as you can see here in these studies that you can see in the slides, from the very first ones from Brakuwan and the Anderson, all the way to Mikalski in TOG, they've demonstrated that around the fact of increasing 10%, 10 grays, excuse me, 10, between 8 and 10 grays, you increase the biochemical control in around 10%. So this is a very interesting trial, a British trial with 843 patients with a mean survival rate of 10 years. It's very interesting. And what they found here, as you can see, is that this is a randomized study. There were two arms, and the increase of dose in the group of 74 gray with conventional fractioning increased 12% the survival at 10 years compared to the group of 64 grays. So this is the curve, the graph that you can see on the left, but on the right, you can see that this was not translated into global survival rate, as I mentioned at the beginning of my presentation. Also, we note that the fact of increasing radiation, this meta-analysis from Vianney from this journal in 2009, can increase the toxicity both genitourinary as in the GI. And this is something we've seen for many years. In my practice during the first years, because I did a fellowship in Canada, when I started using the new radiation techniques of prostate cancer, I saw too much toxicity. When I talk about a lot, I talk about 10% of patients with grade 3 toxicity in the GI, which was the one that called our attention the most. And so in the first 2 years, 3 years that I was at the hospital, I decided to write a paper about the role of to coagulate telangiectasias in the lower rectal area, where there was important toxicity here. So through the years, I don't see this anymore. In fact, now I I'm not of the 2,000 to 2,500 consultations to do per year. I won't see over 3 or 4 cases with GI toxicity today. I'm not bragging, is this just simply things are improving. Why is it important in prostate cancer to increase the dose, especially dose per fraction, due to the alpha beta? We know that prostate cancer has an alpha beta that seems it's calculated to be, it's around 1.6. There are many studies that have seen this, and well, we try to look for the sensibility of the prostate cancer, and we looked at the alpha beta, and that is more close. It's 1.5, 1.7, 1.6, 1.8. So this is an alpha beta that clearly supports to use hypofractionated schedules. So as I mentioned before, but we're going to say this many times through this session, we're also seeing an impressive increase in the possibility of brachytherapy in most of the centers where we all work. We can do this, and we have great alternatives with precise radiation doses. We're able to do an IGRT with high precision. It's great. And there are other technologies here that demonstrate that they can have important role, like cyber. And of course, in prostate cancer, you cannot talk about hypofractionate or ablative dose without talking about brachytherapy. And I'm sure that even though it's not today's topic, because I'm a passionate about brachytherapy, I do a lot of that. I don't do seeds, I do high rate brachytherapy. And in fact, it's one of the things we do the most in our service. Protons here, you can see it. In reality, in prostate cancer today, they haven't been able to demonstrate that they're superior to external therapy with tomo, cyber, accelerator, or brachytherapy. So all this technology has allowed us to do this, from going from that initial line of conventional radiotherapy. Many sessions when I started working prostate cancer, we did 39 sessions to our patients, to other more hyperfractionated schedules to 28. And now we're in the cheap, which is 20. But today, when we want to hyperfractionate, we use specially that we use also moderate, but especially we do these hyperfractioning. If you look at the American guidelines, you can see they talk about conventional that could work in everything. They talk about ultra hyperfractioning. They say that, well, you should be careful with the nodes with metastasis, but you can see it in all. And as you can see in the first row, hypofractionated treatment is a treatment can be used, and the evidence supports its use in all situations. So this, it's dual, the evidence, it comes from the two very relevant trials, the Canadian and the British trials. The first one here is the British trial. It's called CHIP, where, as you can see here, it's a randomized studies. The great majority of patients had intermediate risk, and they were divided into 3 groups. A group with standard doses, a little bit low, but standard, 74 grays in 37 fractions, and 2 hyperfractionated groups, one in 60 grays in 20, another one less fraction, 57 in 19 fractions. If we look at the type of patients, as you can see, 70-something% of patients had moderate risk, 60% were in Ganglion 7. And this is very interesting here. If you look at how they were classified, you can see that about 60% of them had a classic treatment, 3D conformed radiotherapy. There were no patients, or more than half of patients didn't have IMRT or any other type of inverse planification. So if you look at how brachytherapy was administered, it was not, we didn't use guided image, no image guidance. And in this study, more than half of the patients didn't receive this type of technology. So you could see 30% had image guidance. So it was followed up for 5 years, and this is what this study found out. It was a study with a non-inferiority design that demonstrates that yes, there was no inferiority of the schedule of hypofractionate of 60 grays in 20 fractions of 3 grays per session compared to the classic one of 674 grays in 37 fractions. If you see, there were over 1,000 patients per branch. It's one of the studies we have in cancer that has been published nowadays. In these studies, we also looked at secondary effects, and this is also interesting. We need to know that when fractionated dose are higher, the timing changes of the timing of secondary effects show up. So the schedules of 360 grays per session through 3 grays developed secondary effects a little bit earlier, as you can see in the graph, red and green, compared to patients with conventional fractioning. Patients take a little bit longer to develop that secondary effects. Nevertheless, these secondary effects are also solved faster. So this is in the two types of secondary effects, both in the dominion of the GI as well as in the urinary secondary effects. So you can see here, we see the incidence at 2 years of how much toxicity we had in the arms. We see that the group of 74 grays had a grade 2 GI, almost 4% of toxicity. In 60 grays, 3%, and the other one a little bit better. So we've also have a special group where we only gave one session of 57 grays in 19 fractions. And you can see that in the elderly patients, there are no differences between these two arms, between the arm with the, between, when we give 57 grays, it doesn't matter if the patient is older or younger because the disease control has the same result. And they also find that 57 grays, you cannot say that it's non-inferior to 74 grays. In other words, in these studies, you cannot say that 57 is as valid as 74, and that maybe 57, it's a schedule that we need to know that could be a little bit inferior to 74 grays. And let me explain to you how I get this data. I understand this data, how I use it in a daily basis. So here in the patients of 75 or older, they 74 looks worse than 57 and 60. We're looking at 5% a year difference, but it's not too much in terms of the disease control within the groups. And then they also look and find that the elderly patients, which is something that can be found frequently, is that they have more secondary effects from the GI point of view and from the urinary point of view, and that in the elderly patients in particular, you can evaluate the possibility of decreasing the dose to try to mitigate those secondary effects. I'm going back to these slides because I'm going to share with you what I do, how I include these results in my clinic. Well, when I have a patient during the consultation, I want to use moderate hypofractionated treatment, which is valid for almost all patients in our consultation. Well, what I do is 60 grays to all patients. In general, I accepting patients that I consider that have greater risk to develop secondary effects. Which are these patients? Well, patients that are elderly, more fragile, There are elderly with more comorbidities, patients with previous manipulations of the prostate. For example, patients who have had previous RTUs, transurethral treatment, that they have been manipulated. We know that that manipulation can cause secondary effects, and in knowing that 57 grays was better tolerated, even though we lost a little bit control of the disease, well, I use 57. For the rest of patients in general, 60 grays in 20 is how I feel more comfortable. The second is a profit trial. Okay, I want to ask you a question now. There are several things from the chief that I believe are great. And the ASCO GDU of this year, they published the 10-year update and they confirm what you are telling us. So this is great because these long-term follow-ups make us feel much, much better how this toxicity works. But I would like to ask you, and this you can tell us when you talk about your practice, do you see a limitation that only 12% of patients were high risk when they were included in the study? Because we saw it's only 12% in each arm. And what determined that they were high risk was the Gleason size. The sizes were relatively uh, low test. So what do you think about the 12 high risk for the chip? Well, good. In my personal opinion, is that it can be placed in high risk population. Using conventional fractioning has no determining role, should not have it if we're able to use high volumes. Because why? Because we know we can use with the hypofractionating schedules treatment on the nodes in a safe manner. So if we're concerned that cheap is that it was on the prostate and not on the nodes. But I'm not going to talk about this today because it is more about hypofractioning. We can discuss it later, but I think it's, I had the opportunity to be in Vienna a while ago, a couple of days ago, and this is so interesting. We were with Dr. Murphy, the first author of the POP RMRT trial. We talked about his trial and the fact that we of treating the nodes or not with all the limitations. And it seems clear that if we want to do moderate hyperfractionation on the prostate and a little bit on the nodes, it's easy to be done, can be done. So that cheap, and this one that I'm going to present, the profit studies, the volume of patients with intermediate risk was very low. And I think that in all the guidelines, it says that it's reasonable to use the schedule to high risk patients. Why? Well, because the biological dose that we administer with 60 grays in 20 is as the same as we use when we use 78 in 39 or 76 in 38. So to the same biological dose, this is a personal opinion, okay? If we're, it becomes something safe. There's an author that says, well, it was a more aggressive tumor, so we can have a different alpha beta. So that benefit of radiology that we have, we can lose it. There are not pivot studies that are huge that say that talk about the role of hyperfractioning in high risk, but everybody agrees with this data. And if we compare the results in general, the literature, with a smaller series of moderate hypofractioning, although they are not pivotal studies, the disease control results are the same or even better than what we have in studies such as CHIP or PROFIT. Great, thanks for clarifying this of high risk, because I believe is something that we need to know. And to close here, because we're not going to talk about pelvis, but do you use the 25 sessions, 50 grays to the pelvis and 66, 68 to the prostate with integrated boost to the prostate? Well, when we use the pelvis and we use hypofractioning there, we have two different schedules. One is one of the ones we used is 60 grays in 20 fractions on the prostate and seminal vesicles, and the pelvis, it goes to 48 grays. In other words, 2.1 per fraction. That's one of the ones we used. And then the other one is 65 grays in 28 fractions. Excuse me. Wait, since it is pre-established, I think it's 65. Okay, let me check. Because we already have this in our template, so I don't have it in my top of mind right now. So yes, it is 65 and 25. And then we give 50 to the pelvis. Great, doctor. Thank you. And you can continue. The second study is this one, Canadian study, Profit. It was led by Dr. Catherine, published in JCO in 2017, and they used 78, 16, 20. The characteristics of our patients, as you can see here in this trial, most patients had lower than 10 PCA. Also, most of the patients were with a 7, 3. In other words, it was a population with a good prognosis. They were randomized, 1,200 patients were randomized. We didn't do hormone treatment because they were good prognosis patients. And we found that with 5 years of follow-up, the survival free of progression was 85%. But more than 85%, you should look at these two curves that are superimposed in this graph, both conventional and hypofractionation. There is no difference in terms of the disease control. Also, they looked at event-free survival. Here, there were a little bit more metastases or death events, but there were no significant difference in terms of survival rates. They also looked at the toxicity. Excuse me, this image is a little bit blurry, but it's important to clarify that there were no differences in GU toxicity in both arms. So this confirms the idea that we have that it is very safe to do hypofractionated radiation treatment. And when they looked at the GI intestines toxicity, they found a little bit more of acute GI toxicity in this cohort of patients where we didn't use great technologies but it seems that in the long term, the toxicity in the hypofractionated group is not worse, even it could be a little bit better. In summary, well, moderate hypofractionated 68 and 20 is the one that we use more frequently. It's equivalent to any other studies, longer studies with conventional hypofractioning. So this is the most relevant information we found. So this was the first part of my session. And I would like to, I don't know if it's possible, but I would like to, I had a couple of questions. They're not academic questions, just to understand the advancements we have today. Yes, we have them in the poll, Zoom poll. So you want us to ask the questions? So it's interesting to note this. So this is the first. Which type of treatment is most used in your department? Normal hyperfractionation, moderate, or ultra? Please recall, if you have any issues to answer the question, you can send it through the chat and we can see the answers through the chat. So it seems that 50% use normal hyperfractioning another 50% moderate, just a very small portion of the participants use ultra hypo. So this is enough. It's impressive. I had never done a poll where there were so many people answering. Wow. So let's move to the second question. So in terms of technology in your hospital, you're able to, one, because we're talking about technology, the type of technology that you can use at your hospitals. We can only do 3D conformal RT, IMRT, IGRT, or do you have more technologies? Can you do adaptative radiotherapy, LINAC, intrafraction control? I tracking and control, I believe it's a little bit more. It's with Combin CT, 70% of IMRT and IGRT. It's interesting data. There's technology to do IMRT and IGRT. Nevertheless, they do lots of normal hyperfractioning, normal fractioning. So let's ask the last question. Okay, this is also about technology. So in this one, it's just knowing if you use or not prostate brachytherapy at your centers. And does it matter, HDR, LDR, any of them? Most don't do prostate brachytherapy, just 50%. And I asked this because as we started doing hypofractioning with brachytherapy, it was to explain a little bit how this could help people to implement a program. But okay, 1585, I think we can move on. There's a last question. It's about confidence. So with that technology available in your hospital, are you confident enough of being able to use or to start a moderate hyperfractioning program or SBRT? Very interesting results. Yes, only 12% believe no, they don't. 70%, 60% yes, 60 yes, but they need a push. And 30%, they are already doing it. So with this, I am very clear the type of audience we have. And these are great news. I think that we will be able to, or you have that possibility to start to do these type of treatments. What's not clear for me is in the LATAM countries, how are you doing with financing? The fact that, well, there are some countries where the reimbursement depends on the number of sessions. So if this is still like this way, it's an issue. Yes, it's still this way. The first session of the curriculum was to talk about, let's say, the payments and a little bit about hypofractioning. And I know at least that in Colombia, we have a bundle payment system, which means that the whole treatment is paid independently of the number of sessions. But what we learn in these sessions with our participants is that there are countries that those countries work differently and still they are paid per treatment session, which could be a limitation. Alejandro, would you like to add something before moving forward? Yes, Alfonso. Let's say that talking with our colleagues from different parts of Latin America, countries such as Mexico, Brazil, and Chile, depending of the system, or because they have like a mixed health system where there's some that are kind of public sanity and the others are like in a private system. Well, they don't know if it's paid per bundle per session. So in the group, there's some saying the Paraguay says that they're doing by fraction. Mexico, they're paid per fraction. Venezuela, it's paid 100%. So I would understand that as a bundle payment. As Maria was mentioning, we in Colombia, we have an advantage, which it doesn't number of sessions, 1 or 100. Payment is per bundle. Yes, they said that that in Bolivia there's no issue, but there are countries that do, as in the US a couple of years ago. It was by number of sessions, and that was that normal high fractioning was used more frequently due to this. So we would need to ask something else. So if you didn't have any economical issues, that percentage of people who say that they don't do it, but I would do it, could be because of the economical factor, because this is just talking about financing. Here in Spain, we've made it change. I'm talking about private insurance because we have public system where, well, there is no reimbursement. We can do whatever we want. We can do anything with the prices, but in private sector, there it's very different. But here, what we conceived is that we pay for the technology, the complexity also, so that helps people to do more precise treatments. So if the so they charge the higher for this fractionated treatment, that for hypofractionating, promoting the use of hypofractionated. So let's move on. I know there are questions about IGRT. So when you share with us how you use them in your service, we should answer those questions. Excuse me a second. You see that my screen, Maria? Yes, perfectly. Even though I know that we're going to talk about, well, we have to know more about moderate, especially the, we need to know about the trials done. And I would like to make this small introduction to clarify some concepts, and then we can talk about my daily practice. Why have we started to use high doses per session treatments, not moderate? Well, because one, there are many centers in the world that started to do it over 10 years ago, and they've demonstrated some in a retrospective, others in a prospective manner, with not very large cohorts of patients. They've demonstrated that it's safe to do this and the results are okay. So that's the most important data in this analysis. It's a publication done a couple of years ago. You see 6,000 patients and a moderate mean, follow-up mean of survival free of disease. It's 95%. So in these years of patients, most of the patients treated with the SBRT were very low risk patients as well. And we also have other data like these two institutions, many treated patients. We're talking about 2,000 patients, and they show that they have good prognosis with magnificent disease control. But finally, we already have data of randomized studies that are going to give us evidence, optimal evidence to decide if SBRT is the path or not. In my opinion, we have it here. SBRT is here to stay, and we will, in good prognosis patients, there seems to be no data to say, well, so the first trial is hypo-RTPC, and the only study that we have today with data of effectivity of SBRT with level 1 evidence is this. And then we have the PACE, that it's more like an umbrella that teach the rest of the world how to do randomized studies and how they're doing, to see if we can learn. So the Hypo-RTPC was published in 2019 by Wildmark. This is a trial fundamentally in intermediate risk patients. It's important to mention that most of them, of the patients, of treatments were done. They had something that is, for me, it's important, and I'll show you, is the authorization of fiducial markers. If we don't have any other technology that could replace the use of fiducial markers, then this is a good strategy. But I think that this that you see in the last graph is important. 80% of these patients, even though they had on almost SBRT schedule, planification was that with 3D conformed, only 20% received an a UVMAT or an IMRT. So this is important when we look at toxicity and disease control. So what do I found? The schedules used in are 78 grays in 39 fractions, the longest, versus 42.7 in 7 fractions. We talk about 6 grays. Excuse me, no. Let me check. What is a dose?
6,1, sí.
It's 6.1 grays per session. Really, there's some authors that say that this is not ultra hypofractioning because we have to increase the dose even more. So this is like a moderate, almost. So these are 7 sessions, 39 fractions, and you can see at the curves, they are superimposed. There's no advantage to do normal versus the new fractioning that they are studying in this trial. So I defend brachytherapy every time I have to, let's say, I have to fight with important authors, not about, I always use these graphs because there's kind of a relax that, and as when we escalate the doses, I think we can have more biochemical control, but this has been not been demonstrated. This is the only trial available, and SBRT is not better, absolutely not better. So we can use CBRT, but it's not better. It's as good as conventional treatment. About toxicity, well, ultra hypofractioning has a little bit more toxicity, acute toxicity, basically in the GI at the beginning of treatment, but it normalizes. And from the toxicity point of view in the urinary tract also, it's more acute, but at 3 months follow-up, there is a normalization. You see, you can superimpose these tables. So these are symptoms reported by patients. Second study is the PACE, which I believe you know, that we found data of PACE A, that they randomized surgery, but we still don't have definite information yet. This is a study that hasn't been able to recruit as many patients as they wanted to. But the important thing for us is this. It's a PACE B trial where they did 20 sessions versus 5. And what they find is that SBRT is well tolerated. Toxicity, there is toxicity, but it's not way too important. In fact, grade 2 toxicity, as you can see here, was very similar between one technique and the other, moderate and high risk, even though you also have to consider that at 2 years, the acute toxicity, well, let's say that a percentage, around 20% of patients where we are producing symptoms. But I also think that we also produce this when we do moderate fractioning. And we need to recall, this has been shared, that base B didn't do as high quality SBRT, but with a moderate quality. There's some controversy that we have today. If we start to do treatments instead of 39, 38 sessions, not to do 5, well, there's some things now that are now showing up in the literature, the scientific evidence that says that it could be a little bit hard to use those 5 sessions with all the new advancements. For example, if we give 5 sessions of prostate, what do we do with the nodes? Do we also treat them in 5 sessions? Or should we do different treatment for the nodes and for the prostate? The second, we're not going to be talking about brachytherapy, but the third one is boost on the intraprostatic dominant lesions. Well, we need more technology, echoes, and there are studies that I'm going to mention, like the FLAME study that has demonstrated that increasing the dose on these nodes and the dominant nodes will improve the results, and there are certain doubts of the amount of technology necessary to really do the SBRT. So I'm going to go very fast now. There are studies that demonstrate that 25 grays in 5 sessions on the pelvis and 40 versus 30, 40 is can be done. It's well tolerated, low impact in the quality of life, and it could be a path for patients that don't treat acute cases. That, in my opinion, I think it's not clear yet, and probably it's not necessary in most patients. Second issue or important topic is the boost to dominant intraprostatic lesions. Here you can see different schedules, especially of the group of the Netherlands, the Kapmeyer, which is the flame, and you can see 4 studies in 4 different colors from standard that you do there, which is conventional fractioning, radiotherapy of the whole prostate, and we don't increase the dose because they didn't have that initial data. The flame study, a trial, is also done with conventional fractioning, but our concomitant boost can be done to do to tint the tumor, the dominant area, and this is also done in 5 fractions per week, 5 sessions. Does it mean that they're using hypofractioning in order to treat that tumor? Prostate, if it receives 18, it's conventional, nevertheless, the tumor keeps growing. So when these data were published, one of the criticisms made was that, of course, in a time where many worldwide centers are doing fractioning, a moderate or SBRT, as we integrate this to a concept of escalating the dose on the dominant nodes. This is just an anecdote. So we have all these other trials, flame 5.0 of, we talk about tolerance, but demonstrate that doing the shorter schedules is possible and they are well tolerated. So we need to demonstrate that to integrate the increase of dose or increases the control of the disease. The results of flame, the conventional is this, as you can see, the randomized arms were 77 grays, 35 fractions with a boost of 2.2 gray per fraction. And the mean was, and the patients had aggressive characteristics. And this is the only trial that has demonstrated that escalating the dose on the dominant nodes and increasing it above the traditional dose of the stomach would increase the survival free of disease survival. So these are very, very interesting data. So nowadays, we have so much technology. We have MRI and accelerators. We do have the Truvium, we have Versa that we know that can work with no filter, with high rate doses, very quick treatments with high precision. Of course, tracking online. We can use rectal spacers and all these type of things that allow us to do the treatments to be more comfortable how we do the SBRTs. But it's absolutely necessary to do all these tests? Well, in my opinion, no. And it's my opinion, and I believe it is well based. 80% of patients with 3D confirmed radiotherapy, sharing this information with the authors and a good friend. In that base piece, British trial, that technique used for SBRT was not very high. And I also truly believe that with a little bit of technology and a little bit of being careful, it's very safe to do as SBRT treatment. So it's been interesting because that the physician from Bombay and Murphy did his slides, and they were asking about these topics because they also have good studies with SBRT. And we were asking how they do things there because, and basically he was saying that we keep it simple. And many people laughed, and he was right. And SBRT, simple SBRT, you don't need to do many fancy things or wow things, because we can improve a little bit of the precision if we use certain things. Can we improve the toxicity with spacers? Yes, but using not very complex things like 3 gold fidus last technology machinery also use a tracking of the fiducials. Conbeam can make us feel very safe of reducing the regular margin and to have ablative doses with good tolerance from our patients. But it's crucial when we start one of these programs to check very well because if we don't audit our results, we don't know if we can be compared with the centers, the leaders, worldwide leaders. So I think that's very, very important to have a good small database. If you can go run it through the ethics committee of your hospital, do a prospective registry of that data. It's 15 minutes per week to introduce the data of the patients, and it provides lots of information. And for those who like to publish, or if you don't like to publish, well, at least you have the results in your patients to know which results you must improve or not. And why do we need to check the data, audit our experience? Well, because we know of many trials that what the physician detects when they interview patients many times isn't that reality. The patient sometimes suffers more diseases than they share with their physician. Since we're talking about moderate hypofractioning, how prostate cancer treatment has changed, well, I believe it is important to check this. These are more slides than what I usually use for teaching purposes, but I think that this is very relevant to talk a little bit about the technology and toxicity, how they are impacted. There are 3 very important variables when we talk about radio-induced toxicity. With these clinical variables are the fact that a patient has a larger prostate, who have greater possibility to develop urinary toxicity. That's the evidence. The fact that a patient has IPSS symptoms that are greater before starting treatment will have different results. There are other dosimetric variables. If we have better dosimetries, if we can be safe with lower radiation, but all these aren't valid if there are molecular or biological. So we know patients that have great histograms can do have lots of toxicity, or the other way around. So why? Well, because there's genetic data, and this has been studied, even though this is a topic I don't know too much about, except about SNPs that can be done to patients to know if they have great tendency to develop all these effects. So that's why integrative models are going to be so important in the future. We've also known that with this increase of the precision of what we did a couple of years ago with 3 or 6 box fields versus what we do today with the UV mat with high doses, well, that dosimetric area since the 2000, we are improving the histograms from 2005. We have more publications talking about the risk factors. And for example, the fact
O
of
los pacientes
using
que han tenido
anticoagulants or patients with previous GI surgeries have more gut toxicity, etc., and as all and the biomolecular and genetic information. We've seen this graph before. From the dosimetry point of view, this is what I've lived at my hospital. This is histogram done by hand for me, where I write the type of histogram that I saw in the healthy organs a couple of years ago, which is the red, and this is this red line. Nevertheless, in the last couple of years since we started, it's 2015, last 15 years that we got the new technology in my histograms, dose volume, we try at least, well, I mean about the curves of the patients in those healthy organs, we want to have this shape. And with this, we've reduced in a drastic manner the incidence of secondary effects. And this is not the only thing we have as a goal. We want to improve the dose, but if we don't have a good control of the dose, in other words, if we don't know if we are uh, with drawing our target or drawing a risk, and two, making a good control, treatment control of the image or intra and interfraction, then all these could suffer, especially if with the margins of our target. But this evolution is very evident and very important. So you can all, one, use this type of histograms for healthy organs in your treatments, and that you feel more comfortable because when the histograms are appropriate and the technology is enough, it's very safe to do moderated hypofractioning. So is a patient. Let me enlarge the images, but these are small details that make the difference. This is a patient with prostate cancer with SBRT treatment. And you can see here right now the image that you see in your screen. This is a prostate axial image. We see 95% of the radiation dose that covers completely. The coverage is magnificent. And we have here another graph where we see the same thing. It covers it completely, but there's a little bit of leak in the areas, in the lateral areas of the prostate. Why does this happen? What did I ask the physicians in this particular case? Well, here in this image, we see 50% of the prescription dose. And as you can see, 50% as 90% or 95% is adjusts very well. We see it adjusts to the area we want to treat. Nevertheless, if we have 50% of the dose, you see that it goes into the rectum. So I talked with my physicians and they said, this is something interesting. We found optimal dose, but that 50% of the dose in the rectum makes me scared. We can keeping the low coverage of that area. So this is what they do, only working a little bit longer. And we went from a situation such as this to a situation such as this, where I feel more comfortable with the SBRT treatment, where I know that 50% of the dose that will go to the rectum is lower. So, of course, how do you know this? Well, we don't know this. There's no definite data about this, but I believe that if we're able to use dosimetries for optimal doses, well, we'll have better gains. So this is a dose volume histogram of that same case. We complied with the constraints of the phase B. We complied to them completely. In brown, we see the rectum. In yellow, the bladder. And when I asked if this could be improved, what they did was this. And you can see we went from an initial dose of 90 UV18, 20% of a V18 to 20%. Now we have a V18 of 10%, maintaining exactly the same coverage on the other area. So this is absolutely possible if we work dose and dosimetry in our devices. I'm not a physician, so if I said something terrible, please excuse me, but this is what we do with our physicians team. And we try that our histograms to have more this look than this one. And with this, I finished. So, okay, I agree with something, which is something that is SBRT is here to stay. Specialist physicists, I'm sorry, I said physicists. They were physicists while I was translating. So here we treating pelvis in 5 sessions with SBRT. I think it's great, especially. So there are many questions. So can you please share about your protocols, how you prepare and treat patients? But there are two questions that are about how you select a patient for brachy or SBRT. Because additionally, you've said it and we know you're a fan of brachytherapy and you advocate for brachytherapy. So that patient that has criteria for brachytherapy and monotherapy is a patient that can also have criteria for prostate SBRT. So two participants were asking specifically, how do you choose these patients from brachy versus SBRT and what type of brachytherapy you're using in your practice, HRT or LDRT? We don't have any data that help us to decide, especially exclusive brachy or exclusive SBRT. No, I don't know, because at my center for many years before having SBRT, we did HRT monotherapy, and we've changed this. Today, in low-risk patients, we do SBRT. Why? Because it's cheaper, it's more comfortable for the patient. We avoid going through the OR. Well, they do go through the OR because they all get fiducials, but at least the fiducials were done with just a little bit of sedation or local anesthesia. Since we have an anesthesiologist now, we use a little bit of sedation. We take 10 minutes to do this procedure, 20 minutes from the time the patient gets into the OR until the patient leaves. And of each fraction, we do high rate, we do HDR. So we do 2 fractions of 27 grays in 2 fractions with a Morton schedule, with a Sanibuk schedule. And in this case, it would be 2 hours, 2.5 hours in the OR. The patient needs to stay in observation. They can have more hematomas. So there are things that can be more complicated. So since we have that SBRT, we stop doing brachytherapy unless there are patients where, for whatever reason, we don't want to treat the rectum, for example. So we are more confident that low doses on the rectum can be achieved with brachytherapy. For example, last week we had a patient with total colectomy done due to an inflammatory bowel disease. He had multiple surgeries, 65 years of age, intermediate favorable prostate cancer, since the patient is from that Mediterranean area, he doesn't want to have, he wants to have treatment. I'm sure that this happens in your area. There are big difference between the northern and the southern European countries. In the south, people don't like to, they want to have it removed, and unless they are well-educated patients, they don't understand things as much. So, excuse me, summarizing the question, SBRT or brachytherapy in patients with good prognosis? Today we do brachy. It's more comfortable, it's cheaper, and we have a program that works very well with SBRT. Nevertheless, when do we use brachytherapy? How do we select in all patients we believe that have a tumor with a worse prognosis than where we think that exclusive radiotherapy is not enough? We do brachy boost with HDR, and we did in all intermediate risk or unfavorable or high risk patients. If we need to increase the dose, we do it with HDR brachy. We have data about these two, very interesting about the boost with SBRT, and I'm sure that later on we'll have them published. It seems that what has been published up until now are good, great results, but still we don't have papers presented at meetings. So we need to wait for a little bit more to have more information. Okay, thank you, Doctor. And I think that we could go to the practical point of view because there are many questions about your protocols. How do you prepare the bladder, the rectum, the use of IGRT? So go on, because I know you want to share how you started to apply and your transition at your center to hypomoderated. So please go on. And I hope all those questions that have been made in the chat can be answered about the requisites that you have in order to implement hypomoderated. So these are two parts. I already shared this story because I shared with you the last time I met with you in Rayos contra el Cáncer, but I'm going to repeat it because today the audience must be different. And I did some slides of how we do things today. It's something very simple, but just for you to know how we do it. So beforehand, I tell you that we are like Dr. Mursi. We keep it simple. We don't complicate ourselves. We don't believe in starting to use endorectal balloons, etc., etc. We like to do very little things. And even though I don't have it here, if you want to see the results that we've reviewed, because we audit the results, you can find them. So let me share. So let's start with my personal experience. I already shared many of these things. We are a center where we do lots of brachytherapy, HDR brachytherapy, especially due to my background during my residency. I was trained in brachytherapy. I had the luck to have with Dr. Hanita Cook, a Canadian. I did a fellowship in Toronto at Princess Margaret, and I also had the opportunity to be with Michael Zaleski and do a fellowship with the American Society of Brachytherapy. So with all this background I had, well, we started with a very intense brachytherapy program. Since 2010, we convinced our radiologists so all patients with prostate cancer could have a prostate MRI. It was a little bit complex because the machines were very saturated at the time. Today they're still, but we defended that. We thought that it was more important to have the information provided by the MRI, and that we needed to do it as a priority compared to a knee or a shoulder MRI, which is what really used most of the MRI. So then we started using MRIs for everyone, and since 2014, we changed. We went from HDR brachytherapy to do IMRT. The machines were old, 15 years old, with low dose rate. They didn't do cone beam. We only could do portal images. And we saw the light when we started to use the fiducials. We spent 4 years from boost brachytherapy. Then we changed to 3 fields, removing the posterior field. And the truth is that doing brachy boost allowed to do high radiation. And since the area was small, that and it was not toxic, we published this in the Green Journal in 2016. Excuse me, no, 2018, with a 4-year follow-up, and it was treatments were well tolerated. But we saw the light in 2014 when we started using fiducials. For those of you who are doing or can only do conventional plaques or portal images and you're matching the bone, we were really surprised when we started using the fiducials, seeing that once we matched the fiducials, the bone sometimes had 1 centimeter of distance. So you need to match the bones. There's an important risk that the prostate is poorly treated and that they are receiving, the risk planes are receiving more dose than planned. So this is an issue because the bone matching is very important. Since 2016, we started, as you know, in Spain, there has been a very important donation from the owner of Inditex stores, Sara stores. He donated the last proton machines, almost $1 billion, and which has improved the panorama of radiotherapy. Now we can do VMAT, and we started to do VMAT in all patients with daily cone beam and fiducials. And since 2019, we started our SBRT program with VMAT with 2,400 dose with no planning filter and besides that, we've implemented online tracking of the fiducials. So even though this sounds as many things, well, it's keeping it simple. Patient is on the table, we do a cone beam, we fusion the cone beams, we do the fiducials, we do online tracking. We have an algorithm that if any of you wanted, we can share it of how to do with the fiducials.
De hecho,
And
consiguen unos técnicos de máquinas, los que trabajan en las
technicians who work in our devices do things by themselves. They feel very comfortable because during the treatment, every 5 seconds, we have a fluoroscopic image of kilovoltage where you can match the fiducials. In case of a fiducial is outside of a range that we mentioned, they will stop. They do a beam hold, and every 5 seconds they have an image. So if the match is well, then they start all over again and finish treatment. We take around 1 to 2 radiation minutes each session, doing 8 grays per fraction in the prostate SBRT. It's very quick, it's very comfortable. And so this is a summary. We start with this brachytherapy device that you see here. Team. It's the 4 of us. Our classic scheme was this: HDR brachytherapy, 15 fractions. In 2014, or until 2014, what we did this was a 4-field technique. As you can see there, the conversion of the dose was not that good, but since the dose was only 37.5 grays, we didn't, the toxicity was fair enough. This is what I was saying before, the bone matching. These we found that was not appropriate, and this we discovered, well, we already know it due to previous papers, but we saw it directly, and so we started to doing fiducial guided treatments, and we still use them. Maybe today they say that you cannot stop using them. I try to use other ways to fix the prostate with the endorectal balloons and so forth. But no, this works okay. This is comfortable, very comfortable. The radio surgery are to use fiducial, so that's what we do. From 2016 now, we have two cone beams and an axiom, and so we can do things like I shared before. We combine SBRT with the tracking and with the fiducials. All these has allowed our margins to change drastically. So it doesn't matter the toxicity we have before to what we have right now. This is due to as technology has allowed us to decrease the margins, the dosimetries that we did back in the time, 2014, the margins were 10 millimeters around the prostate and 7 on the posterior. When we started with the fiducials, we went to 7 around and 5 in the posterior. And now we do online tracking of the fiducials. So we are in 5 around and 3 in the posterior. And if we look at this in terms of volume of healthy organs, well, it is important because this would be a patient with 1 centimeter to the prostate. The prostate is in blue and 1 centimeter of a margin. And here you see the volume we treated. Nevertheless, if we do what we do nowadays, which are 5 and 3 posterior, then the amount, of course, it's lower. So here you have the evolution of how things done. I was telling you before about the margins, 10 millimeters, 7, 5, and 5 and 3, which is what we do today. I also, when I cannot use fiducials to for any reason, what I do is I only use cone beam. So I do 5 millimeters all over. That's it. That's 7 millimeters around. If we have a cone beam, we've been able to do it because we're very comfortable doing our PTUVs with 5 PTVs. So today we're not doing this boost. We don't do them because the boost is done with brachytherapy, high risk. We also published this in a phase 2 in a prospective we developed a couple of years ago. We demonstrate that it's very easy to do with brachytherapy. So since high-risk patients have brachytherapy, we do 15 raised to the prostate. We escalate to 28, 19 in one fraction on the dominant node. And then we do external radiotherapy that has also changed because today we combine brachytherapy with SBRT. 5 sessions, but that's a topic for another class. So these are the conclusions, really. I consider hypofractioning as a standard of care. It's well tolerated, that doing it with carefully, without the need of huge technology, you can do it. Moderate hypofractioning is due to economical reason that cannot be done. But if there are no reasons, economic reasons, well, then it's not logical not to use it. Technology allows us to have smaller margins and better dosimetry. And in the future, well, we were going to be doing extreme hypofractionation. And the last thing I wanted to share with you is this. A summary, how we do, as I mentioned, we try to do very simple. So all patients, when we do external radiotherapy, they go to the OR. We place 3 fiducials, intraprostatic fiducials. We place 2 on one side of the prostate. The other one is contralateral. We place them leveled, not on the base. And the contralateral is in the middle. Since we use portal images, the good thing would be for them to have different planes, but today we use cone beam, so we don't need to have them in the same planes and different planes. To prepare the patient, this is interesting. I believe we used to use a very aggressive preparation. We recommend 500 ml of water 1 hour before treatment, and not urinating until we finished the treatment or the scanner. And then we also asked rectal enema 2-3 hours before the CT scan. Problem, it was not easy to accomplish. The patient felt uncomfortable. Patients with prostate difficulties, many of them had urinary symptoms, and especially the water, they don't relate well because they had a need. They felt they needed to go to the bathroom. They had, so since 2017, 6 years ago, we started measuring the patient reported outcomes to all patients with prostate cancer treatment. And when, after a year or two, we started to analyze that data, and we found that they had hyperacute incontinence, and we hadn't seen that before. So when we checked the results reported by patients, what's happening, they said that we did also something very interesting, which is an experience map from the time of diagnosis to the procedure. And they said that one of the worst time was to wait in the waiting room because they had a water bottle. They felt that they wanted to go to the bathroom. Some had to use diapers because they had leaks. So since technology was changing, we decided to not do active filling of the bladder, and we just asked them to avoid going to the bathroom for the last hour before treatment. So that way we consider we will have a reasonably comfortable feeling. We stopped using the rectal enemas, and we'll only recommend micro enemas 2 hours before the scanner. And these micro enemas can be placed during the radiotherapy, brachytherapy treatment. But we found moderate feelings of the bladder, and the results are as good, and the patient feels more comfortable. He's more quiet, and their overall experience has improved. Those are three
Pues
rate.
pacientes
We and our
este esquema que
patients
hacemos ahora.
are more comfortable now with this schedule. Excuse me, I would like to ask you, what do you mean about microrectal enema? It's an enema that we have that's called micralax. They're very small enemas, this size. The patient places them, they hold it as much as they can, and then they go to the bathroom, and that's all we use. To immobilize trace patients, we use things like this, any of them. This is a typical pelvic immobile. For definition of volumes, the truth is that in the last years, we are following the PACE guidelines that are published here. You can get them online. You can go in and download them. They explain how to do the contour, and we stock both in intermediate risk patients. We choose 1 centimeter. In patients with high risk, we have 2 centimeters besides the prostate. And what the PACE does, something very interesting for us, is that they draw the prostate, and then what they do is create a margin, as you see here, and 1 centimeter margin. In case it is an intermediate, this is a control region, a margin that is the margin of the prostate. And what they do is afterwards, they eliminate the vesicles that are not within. And they do this because they have the idea that the vesicle have large volumes when really the high risk of the seminal vesicles was especially on the proximal area of the vesicle, and it made no sense to make these large margins. So we are following this schedule. Here you can see the difference. Here you see the expansion on the prostate of 1 centimeter in blue or 2 in case it's a high risk patient, and that the seminal vesicle will be all the way here, here in case of an intermediate risk, and all the way here in case of a high risk. You can see it here now. How in the intermediate risk would be here and high risk here. About organs at risk, we do exactly the same thing. Rectum, bladder, urethra. No, rectum and bladder are solid, but the urethra, we don't treat it unless it's a clinical trial that we are obliged to do. So we don't avoid it. What I do, and I talk with this with the physicists because we work in the same team. The only thing I tell them is try to, if there are hot spots in the prostate, to have them above 105, 105, to try to avoid them in the central area of the prostate, to have them in the periphery of the prostate to avoid the harming the urethra. But I've seen that in the toxicity of the I do believe now that the ETRA has no toxicity issues. It's, but this is just my idea that I'm not going to present today. If we do ultra hypofractionation, we do go to the penile bulb and the femoral heads. And the testes, well, we never paint them. We never draw them. So these are the questions we already asked. So I'm done. So it's really late now. I didn't realize it was as late now. No, excellent. I think you answered many of the doubts about the techniques and how you do the step-by-step. I would like to ask a question that we also find it many times, you know, how we change the bladder preparation protocol, but do you use today a volume, a tolerance volume for the bladder when you're doing an LGRT? I don't know. The rectum and the bladder in the simulation are totally different, and you don't know what to do. Should I fill it more? Should I make it go down? So what is your tolerance range and what is the volume you seek for the bladder today? Maria, we forgot about the bladder in the last couple of years. As long as it has a minimal, the only thing that we see is in patients with an important feeling, because that displaces the fact that the bladder is fuller than in the planification CT, moves the, changes the anatomy. That is why we think it's easier for the patient not to do an active feeling. Only just the last hour, for example, it's a man that has continence issues. We tell them to hold it for 1 hour. 1 hour is okay, and there are no issues. So the bladder in truly is something we forgot. There, of course, there are patients that have a very full bladder. We ask them to go to pee, and with the rectum, we have more issues, especially with the rectal loop, and we use rectal probes. Nurses use them to remove gas. Gas is the one that creates problem. Changing the window of the combi CT, we see it's just gas. With a probe could be enough. Otherwise, we will have to do something else. So this is very interesting because we all have the bladder and the rectum at the max, and it's something that was answered. Dr. Diego Juarez raised his hand. I don't know if you want to ask a question right now to Dr. Alfonso. Good morning. A doubt about the use of rectal spacers. That's a question. What alternative do you use? Because I've read about some protocols in space where they use hyaluronic acid. That's my first question. The second question is about at your center, from what percentage of, when do you treat the nodes? Here in Mexico, we have access to do PCMA, that it's cheaper in cost effectiveness compared to PET-CMA, and gives us very valuable information. So gathering the information where they take cut, cut a high point, we know that there could be a benefit if you include the nodes, but they use PCMA. So it was just these two questions. Very interesting, your question. Spacers, we as standards don't use one. In fact, in the prospective series of SBRT, we have over 100 patients without spacers, and grade 2 toxicity is 8%. 10% in the gut, excuse me, urinary 8%. It's very low. It disappears at 1 month, and we haven't needed spacers. So in general, giving a pace type dose, 35 to the prostate and 40, excuse me, 40 grades to the prostate, we're not using, and we're not using spacers. It's true that during the last couple of years, since 2010, I used hyaluronic acid before. Now there are other products like, yeah, specific hyaluronic acid. We use the same as used by plastic surgeons, called Durolane or Restylane. There were 2 cubic centimeters. We used 2 or 3 vials as separators, spacers, and it worked very well. But today we use very little. We only use spacers. Within the clinical trial, we're participating in the largest, the Sabre trial, which is space OR trial in low and intermediate risk patients. In Spain, there are 3 centers participating, and we need to use the space bar in these. But on the other patients, no, I don't see yet the need or a benefit of the using the OR spacer, the price of the spacer. So if it's demonstrated that it improves the tolerance to toxicity and the secondary effects and the quality of life, then I would have to use them. But meanwhile, the evidence is not as large. So I would just say, let's wait for the results of the trial. Let's see what happens. And treating or not the pelvis, well, we usually don't treat pelvis. And I cannot say that never, no. Of course, we treat high-risk patients and we don't use the Roche formulas, for example. And we don't use them not because we don't think they don't work, because we think they don't work. No, because the studies done with 15, 20% cut of the Roche formula are all negative. So we're not convinced. And the POP RT that I've discussed it recently with Bedan, the population is a population we don't see in Spain because it's more advanced than what we see here in Spain. We do a PCA at 45, 50 to all patients. Most patients have good prognosis tumors. So it's a very different population from Emilia, where patients are more locally advanced with higher PCAs. So it's different. So I think we cannot use, or that data, they are magnificent, but what it demonstrates is that the stratification with PCTMA is crucial to know which patients will benefit, and these are very high-risk patients. So who do we treat? Well, patients that we don't like at all, just intuition. And this is not written, this is what we do. I work with my colleague, and in patients with 9, 10 or more poor prognosis, lots of captation in the biopsy course, a T3D by MRI. We look at the pelvis, but in most of the patients with high risk, without locally advanced tumors, we avoid to treat the pelvis because in a series we just presented our data in STR perspective using BrachyBoost, and results are magnificent. We only have 17 patients out of 310 in this prospective study. Only 17 had metastases, and out of those 17, only 5 in specifically in the pelvic ganglia. So irradiating all these patients to avoid a 5%, we believe it's just way too much.